radiography, when we talk it that, the Karjutkar madam has already given a basic or the fundamentals of the radiology, where it has been divided the radiology for us in the dentistry into intraoral radiology and the extraoral radiography. So when we keep the film inside the oral cavity, we call it as the intraoral, and when we keep the film outside the extraoral oral cavity in the form of a cassette or the film, we call it as extraoral radiograph. Extraoral radiographs do we need many times to take whenever there is extensive pathology which cannot be captured into a IOP film or the occlusal film. So pathology related to the jawbone, maybe a benign tumor, maybe a cystic lesion, maybe a fracture, maybe a developmental anomaly, maybe some congenital TM joint diseases, and all these we need to have the extraoral radiography. This extraoral radiography, we also call it as a indirect radiography, because here we don't expose the film or directly like we do it in the IUPA. The IUPA, when the X-rays will pass through the object and directly will reach to the film, while in the extraoral cassette is used and the film is exposed by an indirect way, so it is also called as the indirect way. So this will be always a Viva question: what do you mean by a direct X-ray and what do you mean by an indirect X-ray? So when it is an intraoral, we call it as a direct, and when it is an extraoral, we call it as indirect, because the film is exposed with the help of intensifying screen or the extraoral cassette. This is the extraoral cassette which you see, and inside that, on both the side, there will be an intensifying screen, and inside that there will be a film which will be kept. So the extraoral cassettes, they are made up of aluminum and the intensifying screen. So these are the layers of this intensifying screen. Base, that will be a plastic one, and the main phosphor layer. So intensifying screens, they work with a principle of the fluorescence. The property of the X-rays which is there, that is the fluorescent property. That fluorescent property, which is always been asked in your Viva, so which is the property being used in the intensifying screen. So in the intensifying screen, the property which is used is the fluorescent property. That means the materials which are used as a phosphor, which is there in the intensifying screen, they will absorb the X-ray energy, which is in the invisible form or which is having a very low atomic number. While when they will absorb that energy, and that absorbed energy will be released by the intensification, by the multiplication into the visible form. That means for a single radiograph, if you want to take a IUPA, we expose, rather than suppose you are taking it for the IUPA, you expose it for the 10 X-ray photons. But same if you want to take a skull radiograph or the chest radiograph or the mandible, you need hundreds of the X-ray photons. That we cannot afford, because that will be an increased exposure to the individual. So we do it here with the intensifying screen. So we pass only the 10 X-ray photons, and when this 10 X-ray photons will absorbed by the phosphor layer, the phosphor layer will emit thousands of the X-ray photons, in which the X-ray, your film will be exposed. So the main aim of the using of this intensifying screen is always of the reducing the patient exposure. So when you might have studied even this into the radiation protection. So when we use this intensifying screen, we reduce the patient exposure almost all by the 70%. The phosphor layer which nowadays which are used are the rare earth elements or the rare earth materials which are used, the gadolinium oxychromide and all this. They emit the green light, while the traditional phosphor layer which we used to have a calcium tungstate. So that calcium tungstate which is there, that used to emit the blue color light. Okay, so even the green color light has a more sensitive than the blue color light. So always we should prefer a green sensor or green intensifying screen. Okay. Below that there will be a coat, and below that there will be a reflecting layer which is made up of a titanium, so that whatever the X-rays are passing again through the film, they will be reflected and the film will be exposed with the more number of radiations, and the patient radiation exposure will be reduced. Okay. So this is your routinely asked short note as an intensifying screen which is used in the extraoral radiograph. Okay, and the purpose of this is always to reduce the patient exposure. This is placed in a cassette that is made up of aluminum. On both the sides there will be the intensifying screen, and inside that the film extraoral radiograph that we are going to see it in the coming slides and all this. So there will be always one short note or a long question will be asked in the examination about any of extraoral technique. So whenever any extraoral technique has been asked to describe, you should always describe in these 6 headings. Okay? So if you write down these headings, you will get definitely a 50% marks even with your headings also. So number 1 is what is the indication of that extraoral radiograph. So that means which of the object, which of the part of the jawbone are seen into that particular region or particular extraoral radiograph, that will be our indication. That means if you want to see a body of mandible, you want to see an angle of mandible, you want to see of a sinus, you want to see of zygoma, whatever is there, that will be the indication for that. Clinically, you examine that, you're supposed to, once you find out that the pathology is associated with the mandible, pathology is associated with the sinus, pathology associated with the symphysis, then we should have a click that which of the radiograph the symphysis seen, which is the radiograph for the maxillary sinus, and then we'll advise that the radiograph that we call as the indication. What will be the head position? Okay, so that means the placement of the head position. This will be taken in the extraoral. Either there will be a extraoral table is there, a radiographic table you might have seen, or there sometimes even there is a chest stand. So on that, how we are going to place the head position? That means what will be the position of the forehead, nose touching or not? That will be the head position. Where we are going to place the film in a vertical way, and then the central rays you are passing. So the central rays from a distance always you will be passing, always 10 to 20 inches. Always if you have taken the IUPA, you usually take and you ask the bone is always touching to the skin. But here in the extraoral when you take, the bone is not touching to the skin, but it will be always 10 to 20 inches away from the skin. If it is a more away, like in the cephalometrics, it will be a doubled one, while in the routine extraoral, it will be around 10 to 20 inches. The extraoral centering point can be kept. And then the angulation, how the central rays are passing with the vertical angulation and the horizontal angulation. That will be a different for the different extraoral techniques. And lastly, the parameters. So always like in the RUPA, remember these 3 parameters. What is the kilovoltage, what is the milliampere, and what will be the exposure time for that particular radiographic technique. So for all these 6 points, indication, head position, film placement, central ray, angulation, and the exposure parameters. So this is the lateral cephalogram, which we routinely we take it for the orthodontic treatment, before the orthodontic treatment, to calculate the bone level, the amount of the bone, and to decide the treatment plan. This you might have studied more detail in your subject of the orthodontia. PA view, this is a posterior anterior view. So we call it as the posterior anterior. That means the X-rays will be passing from the posterior to the anterior view. From the posterior to the anterior view. And when the X-rays are passing from anterior to the posterior view, we call it as an AP view. This also will be asked in your MCQs, which of the following is a PA view or which of the following is a AP view. So this is a skull view like you see here, and for us we always you take it for the mandible. Okay, you can see the mandible here which will be taken. So the structures in the complete mandible, the angle of mandible and the symphysis. Okay, the skull structure is more seen sometimes. So always if you want to see the more concentration on the mandible, so we pass the radiation more perpendicular to the mandible instead of to the pragma point, then it is called as the PA mandible rather than the PA skull, or is also called as the Caldwell view. PA Caldwell view, which is routinely for us, we take it to see the mandibular pathology, bilateral for the comparison, the symphysis, the angle. It may be a fracture, it may be a benign tumor, it may be cyst, it may be a malignancy. So this is a PA view or the PA Caldwell, or if it is taken more giving a concentration to visualize the mandible, then we call it as a PA mandible view. PA Waters view, this is also called as a PNS view or the paranasal sinus view. So in which we'll see most of the sinuses, almost all the sinuses are seen. Okay, so we take it for the maxillary sinus, which is with the person. So this will be the maxillary sinus, which is seen, which will be taking. This is the frontal sinus. Then here will be a sphenoid sinus, and here will be a ethmoid sinus. So when it's taken in an open mouth position, then we can see all the far sinuses. When it's taken in a closed mouth position, then only the maxillary sinus and the frontal sinus will be seen. Okay, technique part which is there that you can read, will not go into detail about the technique part. And for routine, which this radiograph which we take it for the Lefort 3 fracture, that means to see a zygomatico-complex region. So that means to see the maxillary sinus, then to see a zygoma bone completely, to see the walls of the orbit, to see the lower of the orbit, you see the nasal septum. So whenever this structure which you want along with the maxilla and the curvature of the mandible will see, but that will not be indicated. So it is always indicated to see the maxillary sinus and the zygomatico-complex region, that means main the buttress, zygoma bone, zygomatic arches, the orbital walls and the nasal septum. Okay. So here the placement of the film and all this that I told you that you should go to the reading, and the indication for this is always to see the pathologies of the maxillary sinus and the palate and the oral cavity. Third view we call it as a reverse down view. This will be a modified PA view, posterior anterior view, same way. So this same as the PA view, except the patient's the position. If you see, patient has a lower down position, so that the more structure which you see is always the condyle and the subcondylar region. Okay, so this will be always taken to see the pathology, mainly the bilateral subcondylar fractures. So whenever there is a bilateral, you see on both the side, there will be a bilateral condyles are seen, subcondylar region, then this will be seen, because whenever there is a fall, whenever there is accident, whenever there is a trauma, an individual always falls on the chin. And whenever there is a chin fracture or the fracture of the symphysis there are most of the time chances are there that there will be a fracture of the subcondylar region. So for this subcondylar regions, we always prefer to have this technique that is called as a reverse down technique. This always will be asked in the viva. If there is a subcondylar fracture, which radiograph you will prefer? So subcondylar region can be seen in OPG, it can be seen in a reverse down, or it can be seen in the various TM joint radiographs which are there. That will be a big. Submento vertex, as you know, this is a base of the skull view. Okay, so this base of the skull view, so mainly we will take it for this zygomatic arch. This is routinely taken in the general surgery to see the base of the skull. For us, if it is routinely for the ethmoid sinus. Okay, but this base of submento vertex which is there, this is always see, this is an antero-posterior view. This will be asked in the viva, which is the AP view. Remember, the submento vertex is the AP view, where the placement of the cassette is behind the skull and the X-rays are passing from the anterior side. Okay. So for us, we always use this modified submento vertex view. This is called as the Jug Handle View, and the indication for this is always a fracture of the zygomatic process or the zygomatic arches of the maxilla. You can see this is a fracture. Okay, so the bilateral zygomatic fractures, whenever there is zygomatic process fractures are there, we prefer this technique. This is called as the Jug Handle View. What we do the modification in this Jug Handle View is that we reduce the exposure time which is required for the submento vertex by the 1/4. Okay, so that means if you are exposing it for the 2 seconds, we expose it only for the 0.5 seconds, so that the X-rays will not pass through the base of the skull, and you can see both the arches in a very simpler way. So it's looking like that you are holding a jug, so it is called as the Jug Handle View. And so always ask again in the viva what is the modification you will do. So the modification which we will do is you will reduce the exposure time by the 1/4. So then this is called as the Jug Handle View. TM joint views, you must be knowing it. three TM joint views. Okay, that is a specialized radiographic technique for the TM joints. A conventional one. One is the transcranial, another is the transpharyngeal, and the transorbital. Okay? So this we call as the trans. So whenever the X-rays are passing through the cranium, we call it as a transcranial. X-rays are passing through the oropharynx, we call it as the transpharyngeal, and the X-rays are passing through the orbit, we call it as a transorbital. Okay? So wherever the transcranial view is there, two techniques are there that again will not go into detail. We had a short of time. This technique is always used to see mainly the joint space. Okay? So that is the articular disc, the displacement of the articular disc or the soft tissue component. Whenever it is affected, so the joint space will be affected, and to that visualized joint space, we always take a transcranial one. You can see by the arrow, the condyle, and you can see the glenoid fossa and the radiolucency which is seen between the surface of the condyle and the glenoid fossa, we call it as a joint space. Okay, so joint space is always totally a radiological term which denotes the radiolucency between the articular components of the TM joint. That means between the superior surface of the condyle and the depth of glenoid fossa, okay, when the teeth are in occlusion. So that means this will be always, as if you want to see the joint space, you take the radiograph always in a closed mouth position and not in a open mouth position. This is a transorbital view. As I told you, whenever there is a condylar fractures, one more view which is always indicated is a transorbital view. So the X-rays are passing through the orbit. So a unilateral and the X-rays are passing within around a point, so a positive 5 degree from the ipsilateral canthus of the eye. Okay? So the ipsilateral, that is from the same side. If you are taking the radiograph of the right side condyle, so the X-rays will be passing from the inner canthus of the right side eye only. Okay, not from the left side. If you are taking the radiograph of the left side, then it will be taken from the left side. So it will be passing from, this again a Viva question, or in your objective type of the question, the centering point for the transorbital view. So the centering point for the transorbital view will be always inner canthus of the ipsilateral orbit. So this will be always taken for the subcondylar or the condylar fractures with whenever there is a mesiolateral displacement. So that means condyle will fracture and it will be displaced, or it will be going towards either the mesial side or the distal side. Then this technique will be always useful for the technique. And the transpharyngeal view. This always to see a gross anatomy of the condyle. Whenever there is a gross anatomy of the condyle in the articular diseases, or maybe in the soft tissue diseases, maybe in the arthritis, maybe in the ankylosis, or any type of the hypoplasia or the hyperplasia of the condyle when will occur, then we have to take this radiograph. So see the gross anatomy, if there is a hypermobility of the condyle in the dislocation, in the subluxation. So in the most of the time, this radiograph will be useful. So X-rays are passing through the same TM joint, then this is called as the right side or the left side transpharyngeal. X-rays are passing through the pharynx. Okay. So in this also, one more question is asked, what do you mean by a Parma modification? So the Parma modifications will be seen or will be there whenever we remove the cone or the port of the X-ray tube. So as I told you, we always keep the distance. So this will be taken with the intraoral X-ray machine. So we remove the complete port of the X-ray tube and we bring the X-ray tube directly touching to the skin, and then when it is there, we'll get the 7.5 inches exposure area only. Then it is called as the Parma modification. So that means whichever the long cone or the short cone is attached to your cone, your X-ray tube, that will be removed one, and the port of the X-ray tube is directly bring near to the X-ray, your TM joint or in the preauricular region, and then we expose it. Then this is called as the Parma modification. This will be helping us definitely to avoid the superimposition of the other side TM joint, because the film is placed on this side and X-rays are passing from this side. So chances are there you will get the image of right side also, you will get the image of left side also. So to avoid that, we will bring the port of the X-ray tube near to the right side so that the right side will be seen and the left side won't be seen. This is a transpharyngeal view, and the question which is asked will be always regarding the Parma modification. This you remember. Next is your OPG or the panoramic radiograph, that is the orthopentomograph, which you are routinely aware of. This is the OPG machine. This is the OPG like your routine. The difference between the OPG and the conventional radiograph, that means the orthopentomograph. This is a combination of three words. Ortho we call as correct or the proper. As you know, there is orthopedics, there is orthodontia, where there is a proper alignment. So that means whenever there is a correct or the proper one, the right one we call as a orthodontia. So that ortho, and then there is another one that is called as the panorama, that means a bird's eye view. A big function is there, we call it the panorama or bird's eye view. That means when you go to the top of the hill and look down towards the valley, you can see a complete part of the valley. So that the same one we can see in the OPG from the right condyle to the left condyle, so we call it the panorama. And very important one is the tomography. Okay. So the routine conventional radiographic which you have seen, the IOP or the now the external radiograph which you have seen, what is that? The X-ray source, the patient, that is your object, and the film, all these are the stationary. Okay. So while in the tomography, what we'll do, there will be a rotation of the patient, or the X-ray source and the film. So here the patient will be stationary and the X-ray source and the tube head, your tube head and the film, they are synchronized with the same speed, they will be rotating around to the patient. Okay, so there will be two collimators in the OPG. One collimator which is there between the X-ray source. Okay, so between the X-ray source and the film, and then after that, between the X-ray source and the object, and after that between the object and the X-ray film. So that means in the routine radiographic extraoral or the intraoral, what you see is that the complete bulk of the object is exposed at a time. But here when there is a rotation, at that rotation one part of the object, so that means not a complete object is exposed at one time, but it will be exposed in a multiple layers. So this is also called as a layer technology. So that with that layer technology, as you have seen, that the X-ray source, once it is start from one side, and then it will be rotating around to the patient's. See, from here it is a start, it will go here and then here, and along with that the opposite speed, you'll see the X-ray film is also rotating. X-ray film is rotating surrounding to the patient also, and the X-ray film is rotating around itself also, like Earth. So it is rotating around the sun also, it is rotating around itself also. So in the similar way, in the OPG also there will be a rotation of the X-ray source and the X-ray film, and the patients will be static. So this is the OPG which is there, which is indicated again for any of extraoral pathology. Maybe a fracture, maybe a benign tumor, maybe a malignancy, maybe a TM joint diseases, maybe developmental anomalies, congenital anomalies. In the pedo patients to see the eruption of the teeth, in orthodontics to see the malocclusion, or n number of this is a routinely radiographic technique you might have seen in your institution, radiographic technique that you see from the right side condyle up to the left side condyle, everything you can see. So we call it as a panel. From here to you see the condyle, you see the glenoid fossa, you see the coronite, you see the ramus, you see the angle, you see the complete dentition, all the teeth. You can see the impacted teeth all here. You can assessment for the age also it is used. You can see there is an incomplete root formation of the third molar and the second molar. So you can see that the patient's age may be after 12 and between 18, because tooth is erupted, but still the root formation is not complete. So for the age assessment in the forensic odontology also, this technique will